Hi, good evening, everyone. Thank you, Dr. Sumita, for having given me this opportunity to speak on this platform. And I would be speaking on the role of OCT, the early diagnosis of glaucoma, that is a glaucoma suspect. Can you see my screen?
No, sir.
No?
Yes, sir.
Starting up, sir.
Yeah, it is coming. No, not yet.
Hello, my screen is visible.
Okay.
Is
Is it there? Can you see my screen?
Yes, sir.
Yeah, now it has come. Please make it slideshow.
Yeah.
Yeah, it's visible.
Wonderful. Okay, so I would be talking on the role of imaging in glaucoma suspect. So what is the standard definition of glaucoma? All of us know that it's a glaucomatous optic neuropathy with the correlating visual field changes. But in the, all these visual field changes appear whenever there is more than 30% of the ganglion cells are lost. But you can pick up these defects very early by doing a good clinical examination. Even when there are not even 30% ganglion cells are lost. You can see over here that there is an inferotemporal RNFL defect. And here again, there is an inferotemporal RNFL defect. But in both cases, the white on white perimetry was normal. So what is the problem? Why we need the additional equipment? We need the additional equipment because we have to quantify this, because glaucoma is a chronic progressive disease. And obviously we have to monitor it over a period of time. You look at this, there is hardly a splinter defect over here. So might not have even lost 5% of the ganglion cell. And that's why the white on white fields is normal. But all of us knows that there is a splinter hemorrhage and a splinter RNFL defect. So this patient has to be a glaucoma patient. But still, my white on white perimetry was not able to pick up. So there are lots of problems with the perimetry. Number one, it's a subjective test. And number two, it picks up the defect only when at least 30% of the ganglion cells are lost. And apart from that, so many things are required. The patient should be educated, he should be well versed and familiar, and he should not have any other condition where he should not be able to, or she should not be able to perform the visual field test. So there is a quest for an objective test where we can quantify and monitor the defect in the very early stage. And the answer is the imaging technology. So the imaging technology available to our armamentarium are the OCT, GTX, and the HRT. But unfortunately, the GTX and the HRT are no more there. The manufacturer have stopped manufacturing them. So we would be discussing about the OCT. The advantage of the OCT is that it can image the macula, it can image the arcuate nerve fiber layer bundle, and it can image the optic nerve head. And what these three are the most important parameters for glaucoma. And this is what the printout we get. We get the DIS parameters, we get the RNFL thickness map, where we can assess that how much is the RNFL thickness has been lost in that particular patient. And yes, we do have the progression analysis as well, which does the linear progression analysis for the glaucomatous defect. But another important hallmark feature of this OCT is that they are able to image ganglion cell complex, the GCC. Why GCC is so important? Because almost 30% of the ganglion cells lies in the glaucoma cell complex. And you can see that they are able to pick up the glaucomatous defect, and over a period of time, you can assess the progression as well. Now, I would like to give you some example. See, this is the first example. You can see that both the disc and there is a little asymmetry. This cup is vertically enlarged, but RNFL looks okay. You can see that the OCT image, and there is a suspicious OCT RNFL loss over here. But on white perimetry, it was absolutely normal. So because it does not fall into the standard definition of the glaucoma, because white on white perimetry was normal, so we did not start the treatment. And look at what has happened. A couple of years later, the same patient is presented, and there was a significant loss of the RNFL. You can see over here, there is a significant thinning of the RNFL. You can see there is a significant thinning of the RNFL over here. And yes, there is a superior arcuate glaucoma. So that is the importance of the OCT. That is the test which can detect the structural changes in the glaucoma, can quantify and can monitor. Look at the other example. This is a one-eyed young lady. White and white perimetry is absolutely normal. And there was a small RNFL defect at 7 o'clock hours. Look at over a period of time, what has happened. There is a broadening of this RNFL defect, and you can see that there was a further dipping of almost 6 micron over here at the single location. So this yellow has turned into red. So obviously this lady has progressed, and there is a clear-cut sign that we must initiate the treatment so the white and white perimetry is normal. The third example, you can see that the white and white perimetry is almost normal. But look at here, same patient. There is a gross papillomacular bundle defect in both the eyes. So all these changes, white and white perimetry is not able to pick up, but yes, certainly, yes, you can pick up by the OCT. But yes, OCT is not absolutely foolproof. Look at here, it's not a tomogram. Both the discs are looking pretty healthy, just 0.2 and 0.3 cup. But look at here what this tomogram says. You know, I do not have the time to discuss that why there is so much of fallacy. This shows almost a total cup, and this shows that almost horizontally near total and vertically also it's almost 0.4, 0.5 cup. So I don't have enough time, but yes, there is lots of fallacies with the OCT as well. So we have to be a little careful about that. You can see that there is an inter-test variability. This test was performed, there was significant dry eye. We put the lubricating drop for half an hour, and then again we performed this test in the same patient. So you can see that there was a significant difference. Okay. And similarly, in the advanced glaucoma, if this patient would have been an advanced glaucomatous patient, then OCT does not have any role because of the floor effect. What is the floor effect? Yes. So that also is beyond the scope of this talk. So I can say in summary that the functional test is the gold standard test, but the functional test cannot be useful in each and every patient and is not capable of picking up the early defect. So we are looking for the test which is objective and which can pick up the structural defect as early as possible, and the OCT is one of them. And obviously, we are looking forward for the OCT for further robust performance, and maybe very soon we will have the OCT as the gold standard for diagnosing the glaucoma and detecting the progression of glaucoma. Thank you very much for your patience here.